Today, we're going to be hearing from Dr. Lynsey Keator. Dr. Keator is an assistant professor and speech-language pathologist at the University of Delaware. She received her PhD here at the University of South Carolina, where she was a valued member of the C-STAR team. Her primary research interest is in the interdisciplinary collaboration between speech-language pathology and neuroscience to further stroke rehabilitation. So today, we're going to be hearing a bit about that work in her talk today called tACS as an adjuvant for aphasia therapy. All right, I'll turn it over to Dr. Keator. Thanks.
Thanks, Lisa, for that introduction. And hello to everybody in person in Columbia, South Carolina, as well as our online audience. It's really a pleasure to be presenting as part of the C-STAR lecture today. And I want to thank both Dirk and Lisa for this opportunity. As Lisa shared, I am currently on faculty at the University of Delaware, but the work I will present today is actually work from my dissertation at the University of South Carolina. And although I'll give formal thanks at the end, it is worth recognizing that this project, although it was my dissertation, was certainly not the work of myself alone. I worked in collaboration with a number of the speech-language pathologists, researchers, neuroscientists, and linguists at C-STAR and beyond, and they all really made this project possible. So I look forward to presenting this work. My aim today is to not only share a little bit about the study, but to make this talk accessible to researchers, clinicians, as well as students, because I think this is important work and potentially may have some translational implications for the clinical field. So with that being said, my agenda in the next 45 minutes or so is to introduce a brief background, kind of provide a lay of the land in terms of aphasia rehabilitation as I see it as both a clinician and a researcher, lay some groundwork for the current study, what we did and how we did it, and then I'll look forward to presenting the results and some conclusions and thinking about, as I mentioned, some clinical implications as well as future research directions. All right. So as we're very well familiar and most people on this talk would acknowledge, we can think about aphasia as a network-based disorder. We know that then when there is a cortical lesion, it affects not just the cortex, but a number of underlying neural architecture, including structural and functional connectivity. And we're also aware from both research and clinical perspectives that neuroplasticity facilitates recovery. And we've seen this in a number of papers, and we're also familiar with the Kleiman-Jones neuroplasticity principles, which serve as the foundation for a number of rehabilitation approaches. Given that, our field has really relied on and turned to behavioral aphasia therapy for the last few decades. And meta-analyses and reviews demonstrate that behavioral aphasia therapy does indeed work. Unfortunately, however, the gains that we're seeing from behavioral aphasia therapy tend to be modest. And I would argue that there is a lot of work that needs to continue to be done in this area. And that in the last few years, especially, has been supplemented by adjuvant approaches, these being pharmacological approaches, as well as non-invasive brain stimulation, which of course is the topic of my talk today. tDCS in particular, so transcranial direct current stimulation, has shown to be effective at improving language and post-stroke aphasia. Transcranial alternating current stimulation, which I'll talk more about in the coming slides, remains to be unexplored in aphasia. And that really was the motivation behind the current study, right? If we know aphasia is a network-based approach, why aren't we recruiting a adjuvant approach or non-invasive brain stimulation that can capitalize on that idea of network plasticity after a stroke and think about stimulating maybe multiple residual cortical areas. All right, so let's lay a little bit of groundwork here and start off by talking about neural oscillations. This remains somewhat controversial in the field, but there is a lot of work to suggest that there are neural oscillations that function within the brain, and that these oscillatory functions occur at different phases where there are maximal points where processing is enhanced and minimal points where processing may be reduced. And that these oscillations really are thought to reflect in internal and innate synchronization between groups of different neurons. And this, like I said, is in the absence of any external stimulation. These oscillations have different speeds, and these speeds are then associated with different behavioral domains. Okay. So as I mentioned, there are points just within a naturally occurring brain without any external modulation where there are points of high excitability as well as low excitability. And as I mentioned, these different frequencies of neural oscillations are thought to be responsible for different behavioral demands. In the current study, and given that the focus here is on language rehabilitation following a stroke, the big focus is going to be on the theta band frequency, which is typically thought to run from 4 to 10 hertz. And this has been shown in a lot of work, both for language processing and production, that in a natural state, oscillations at this frequency can support language. Okay. So I've talked a little bit about the phase as well as the frequency of these naturally occurring neural oscillations. This internal neuronal firing can be imposed and perhaps even modulated when an external stimulation, like for example, a non-invasive brain stimulation, is introduced. And when we think about modulating using an external stimulation, we need to think about the phase and the frequency of the oscillations that we intend to target. So as you'll see here, I had previously mentioned these internal oscillations having periods of high and low processing. We would, in theory, want our external stimulus to be matching these internal oscillations at a point where we're maximizing processing efficiency. And that's shown here in the farthest point to the right. So the idea here is that when we match the stimulation phase and frequency to the internal neural oscillations, we can modulate those internal oscillations through a process called phase resetting, or when the phase is matched to the external stimulus, as well as the frequency is matched, we can amplify the effect of these internal oscillations. So we then are matching the stimulus at the highest point of processing efficiency to yield an entrainment between the outside external modulation, the internal oscillations, and this is thought to be reflected in behavioral performance. All right. So let's transition now to talking a little bit about transcranial alternating current stimulation. If you're familiar, this will be a bit of a review. If you're not, this is a very quick overview, but I'm happy to answer questions at the end of the talk. As I mentioned, tDCS is the most commonly used non-invasive brain stimulation for post-stroke aphasia at this time. Unlike tDCS, transcranial alternating current stimulation is thought to entrain neural oscillations and modulate neuronal excitability in a rhythmic fashion while improving network coherence. So here you'll see the sinusoidal wave form that looks very different, of course, than the direct stimulation. And here we are stimulating and applying electrodes to 2 different cortical areas of the brain, and each of those cortical areas alternates in terms of their anodal and cathodal capabilities. All right, so I mentioned before, right, that we try to use an external stimulation to maximize the processing efficiency of those internal neuronal oscillations. We can do this by both phase and frequency, as I said. In the current study, we're focusing on an in-phase application where the stimulation is applied between the two cortical areas at a 0 degrees phase difference, as well as an anti-phase application where the two cortical areas are being stimulated with 180 degrees phase difference. Okay, so that is our phase component. Our frequency component, which I have here again on the right, the focus for the current study is going to be the theta frequency, more specifically 7 Hertz. So this in-phase application, again, presented at 0 degrees phase difference between the two cortical sites, is thought to enhance synchrony between the targeted cortical regions. And as we see in behavioral performance, when this synchrony is enhanced, behavioral performance also tends to improve. Antiphase, on the other hand, is presentation of the stimulation at 180 degrees relative phase difference across the target areas and is thought to impede network synchronization, subsequently impairing behavioral performance. So transcranial alternating current stimulation, I don't want to go too deep into the literature here. Again, happy to talk about this at the end, but has been looked at in terms of stroke recovery in the domains of both motor and language. But there have been no studies, of course, on post-stroke aphasia and no studies looking specifically at speech production. Previous studies that have looked at language look at more of these proxy measures using the NIH stroke scale, for example. So our thought here and the primary motivation behind this study was to use this tACS modulated activity to induce functional connectivity changes in post-stroke aphasia. We were really trying to capitalize on any residual network connections, residual cortical tissue, in order to strengthen synaptic plasticity and, as I believe it, our common goal, to improve language and outcomes for stroke survivors. So we paired tACS in the current study with a behavioral paradigm called speech entrainment. Many of you may be familiar with this. If you're not, I encourage you to use the QR code at the bottom of the slide to review some of the publications. This type of approach was introduced by Dr. Friedrichsen of CSTAR and the University of South Carolina back in 2012. And there have been a number of subsequent publications which suggest that speech entrainment improves the fluency for individuals who have non-fluent aphasia. And speech entrainment is thought to improve fluency through the presentation of this audiovisual model. So the way speech entrainment works is participants are presented with a video of a mouth where only the speaker's primary oral articulators are visible. The speech is presented at a slightly slowed rate that it still sounds prosodic and natural to a degree, but it is greatly over-articulated. And the speech entrainment is presented in a variety of different scripts that are usually about 1 minute long. Participants are shown the video, they're instructed to watch the video once and to practice along and do their best to mimic what the speaker or the audiovisual model is saying. And this in turn, this practice with speech production in real time with an audiovisual model has yielded really positive results for the non-fluent population. As I mentioned, there have been a number of subsequent publications, about this work, many looking at the underlying neural mechanisms of what makes speech entrainment so successful. One of those was completed in 2021 by my colleague, Dr. Lisa Johnson. And what Dr. Johnson found is that functional connectivity between anterior and posterior regions in the left hemisphere, specifically the inferior frontal gyrus pars opercularis and the posterior middle temporal gyrus, facilitated better speech entrainment for individuals who had participated in this task purely as a behavioral paradigm. There was no stimulation involved. Okay, so the thought then is that perhaps speech entrainment acts as some sort of external gating mechanism, and that this facilitation of practice with this audiovisual model might bolster an impaired efference copy for speech production and potentially improve synchrony between these anterior and posterior regions that Dr. Johnson identified in her publication. So let's turn now to the current study. What I aim to do here was to look at both the behavioral outcomes of pairing transcranial alternating current stimulation with speech entrainment, as well as determining if there was any predictors, so neuroanatomical factors that may indicate who performs best or who responds best to this type of external modulation. So the behavioral effects I aim to investigate were linguistic variables, which I'll talk about more in just a moment, and this nature of entrainment. How well are individuals entraining to this audiovisual model? How well is their fluency in their speech production time-wise matching up with the model? And then second, these brain-based predictors, which I measured and considered in terms of cortical damage and connectivity. So is there a certain extent of cortical damage or a certain extent of damage to connectivity networks that may make somebody perhaps a poorer responder to tACS or a better responder? All right, so these linguistic variables and these entrainment variables, as well as the brain-based predictors, were considered in the context of this in-phase tACS stimulation that I explained earlier, a condition of anti-phase tACS stimulation, and a sham condition. Behavioral effects, specifically the linguistic variables, were determined by considering the proportion of the number of scripted words that the participant produced. So for example, when I explained speech entrainment, I explained that speech entrainment presents a script to a participant. If the script had, for example, 50 words, how many of those words was the participant able to produce on their final practice with the script? Similarly, in these productions, we looked for the total number of tokens. So this would be words that were either produced as part of the script or perhaps other words. And then we also looked at the proportion of errors. And again, this was in the context of the presented script. All of the coding and analysis of these linguistic variables were completed in ChatClan. I won't get into the details of that here, but I'm happy to talk about that at the end. And then entrainment, as I mentioned, was really looking at this temporal distance between patient and audiovisual model. And this was done by deriving temporal and spectral variables that were derived from a time warping analysis. Again, I don't want to get into specifics for the sake of time here, but I'm happy to talk about that methodology further. All right, so we've got our behavioral effects, our linguistic variables, and our entrainment. And I had hypothesized that when participants participated in the in-phase tACS stimulation condition, so the two cortical areas would be stimulated in tandem and synchronizing these areas, enhancing, in theory, functional connectivity, that we would see improved performance. They'd be producing not only more fluent speech, but more of the script words, more tokens, and that they would be better entrained to this audiovisual model as compared to no stimulation at all. When they participated in the anti-phase TACS stimulation condition, I had hypothesized that they would be performing worse for both the linguistic variable production and that they would be less aligned to the audiovisual model as compared to the sham. That this would really disrupt or disturb the synchronization and subsequently their behavioral performance. Okay, so those are the behavioral factors I considered. In terms of these brain-based predictors, I considered this cortical damage and the connectivity measures with respect to these same outcome measures that I mentioned previously. Okay, so did the amount of pre-existing cortical damage have an effect on or predict the proportion of script words produced? Did it predict the number of tokens they were able to produce or the proportion of errors? And I considered this in the context of TACS success. So considering the different conditions they were enrolled in, TACS success was indicated by either in-phase minus anti-phase or in-phase performance minus sham. Okay, so in theory, both numbers here, a greater number would indicate better success with the in-phase condition here relative to anti-phase, here relative to sham. I hypothesized that individuals who had greater cortical damage, so a bigger stroke, would have poorer success with TACS. Okay, and that those who had better residual connectivity, okay, would do better with TACS. They have more there to recruit. Perhaps the stimulation would help them out a little bit more and they would show better behavioral outcomes. All right, so the study design was, as I've mentioned, one condition was the anti-phase TACS. The second condition was the, in-phase TACS. Second was anti-phase TACS, and third was sham condition. And I initially set up the study to look at the performance of individuals for each of these conditions after they received 25 minutes of stimulation. I would measure their output at that point, and then I would examine their output both linguistically and in terms of entrainment following a 15-minute post-stimulation washout period. Give you a little bit more detail about the study design before I reveal the results. The study design, it's worth mentioning that this was proof of concept. As I mentioned, TACS has not been used with populations of speakers with aphasia before. So this was very much examining, does this work? Can we see any sort of immediate effects? This was not a treatment study. Individuals came in for 3 individual sessions, and that was the extent of their participation. Okay, the study design was sham controlled. As you'll see, again, when I review the study design in just a minute, one of my 3 conditions was a sham condition. The study was also double-blinded. As the facilitator and the administrator of this study, I did not know what condition participants were receiving on a given day, nor did they. And both the stimuli and the stimulation conditions were pseudo-randomized across conditions and across participants. So from a bank of approximately 40 scripts, that was all counterbalanced based on linguistic variables, as well as visits to the lab for this study. So participants were practicing with a speech entrainment model while receiving TACS stimulation at a frequency of 7 Hertz across these 3 stimulation conditions, and they received one of 3 script sets. Every time they came in, it was a different script set every time, either A, B, or C, and they never doubled up on the same script set in order to reduce practice effects. So it looked a little bit like this. Participants came in on day 1. They were randomly assigned to a stimulation condition, in this case, in phase. Stimulation was applied. They participated in the speech entrainment paradigm, which again was a series of scripts. They were told to watch the initial script, don't say anything. And then they saw the same script 3 additional times and were told to practice with the script. Once they had finished their 3rd practice, they moved on to the next script. They did this for 25 minutes, and then stimulation stopped, and they continued to practice with the speech entrainment for this 15-minute washout period. Day 2, they came in, participated in a second condition, here, for example, the anti-phase, same washout period and stimulation time, and finally a sham condition with the same washout. It's important to mention here that each visit was separated by a minimum of 48 hours to eliminate any carryover effects from the stimulation between visits, even though these were such isolated and relatively short application periods. So participants included in the study included those with non-fluent aphasia. This recruitment largely came from either participants who had been a part of our aphasia lab for some time, or were getting enrolled in our current speech entrainment study led by Dr. Mary Aitchison. But regardless, they needed to have some baseline fMRI data, which I extracted to create their individualized electrical montages for the stimulation. Their exclusion criteria, I did not include anybody with a global aphasia or comprehension deficits that would impede their ability to participate in the task. Exclusion criteria here is pretty consistent with what we typically see. And of course, they could not have any contraindication for either the MRI or the stimulation. Okay, I have the participant demographics here. So I recruited a total of 18 participants for this study, 4 of whom during the task did not produce enough verbal output for them to be scored. So they were not included in the final outcome data. And unfortunately, we did have 1 participant highlighted here in yellow who was not able to complete all 3 visits. So we did have an attrition rate of 6%. Right, I have a lesion overlap map for our participants here. And I will briefly describe how I went about making these individualized montages for stimulation, because I think that that is not only something that's unique to this study, but is really important to consider when using any type of external stimulation. So I mentioned previously that my colleague, Dr. Lisa Johnson, identified these anterior and posterior regions in the left hemisphere that are thought to be synchronized during behavioral speech entrainment practice. And I also mentioned that participants who were recruited for this study had retrospective neuroimaging data. I pulled that retrospective data to identify areas within anterior ROIs, specifically the inferior frontal gyrus parapicularis, and posterior ROIs, like the posterior middle temporal gyrus, to identify residual cortex as close to these ROI sites as possible. So if they did not have any residual within the left IFG parapicularis, I pulled as closely as possible using a preset radius. Once I identified these sites for each participant, we used MNI coordinates in collaboration with tDCS Medical, in particular Dr. Abhi Datta, to create coordinates for each individual participant. So you'll see here, I've got participants 1 through 18 in the first column. This second column is their anterior coordinate. So this would correspond to some location where they have residual cortex, and based off of their fMRI data, this area was also active in the language task. And then posterior MNI coordinates, same thing, where there was residual language-related tissue, which then revealed 2 different electrode maps for each participant. So the electrode sites remained the same depending on the nature of the stimulation condition, whether it was in phase or anti-phase, dependent on whether the anterior or posterior sites acted as a cathode, because remember, in the anti-phase stimulation, the stimulation delivery is at 180 degrees difference, as opposed to the 0 degrees phase difference with the in phase. So here you'll notice the anodes and cathodes for the anterior site remain the same, but for anti-phase, they are different compared across the two, so that these two sites are not stimulated in synchrony. All righty. So the results. Before I get into the details of our findings, I do want to highlight, I mentioned our study was double blind, and this remained true when we ran statistics on both patient and SLP guesses regarding the stimulation conditions. There was no significant difference there. Patient and SLP, which was me, were unable to determine a difference between the sham and the active stimulation conditions. And we also had participants complete discomfort and pain ratings. These were comparable between both sham and active stimulation conditions, indicating that there was no reported difference between the two conditions. All right. So our study design, as I initially introduced it, looked like this. I will note that there were no significant findings for the washout period. So the findings that I'll present here are primarily reflective of the stimulation condition. So that is linguistic output and entrainment following 25 minutes of stimulation. A reminder that I had initially hypothesized that in-phase stimulation would result in better performance, and that anti-phase stimulation would result in poorer performance as compared to sham or their baseline. What we found were significant effects of stimulation for the number of total tokens, and I will outline this in the slides that follow. And although these outcome measures of proportion of script words and proportion of errors weren't statistically significant per Kruskal-Wallis, there are some interesting patterns that we see in the data, especially given that really only 13 of the participants were included. As I mentioned, there were a few who just didn't have enough output to include. But considering we're seeing these patterns and we're getting the results we're getting with such a small cohort, I do think that they're promising. So this behavioral measure here is the proportion of correct script words that were produced. And here we have the different conditions. So we've got proportion of correct words on the y-axis, stimulation condition across the x-axis. And you can see there is a slight increase, so slightly more correct words were produced in phase. This, of course, is not statistically significant, but it's worth kind of considering in the context of the greater results I'll show you. This is the proportion of errors produced. So again, stimulation condition on the x-axis, errors on the y-axis. And here we see a similar pattern where there's a better performance for the in-phase stimulation condition. This, of course, we're looking at errors, so we hope for a better performance to see fewer amount of errors being produced. And we do indeed see that here, although again, this is not statistically significant. Most exciting, however, was the number of tokens produced. So this particular variable, as I mentioned previously, wasn't looking specifically at the number of scripted words that the participant produced, but if they produced additional words or words that weren't necessarily part of the script, we included those in the token count, and that's what's reflected here. And we do see that participation in the in-phase stimulation condition yielded a higher number of tokens, statistically higher than the sham condition, and although not statistically significant, also higher than the anti-phase condition. So we see a pattern of results here. Again, this is certainly, right, bordering on significance. But we do see overall better behavioral performance with the in-phase stimulation. And again, this is especially notable for the small cohort that I'm presenting here. So those were the linguistic variables. What about this measure of entrainment, or the distance between the participant and the audiovisual model? Okay, here again, this is not a significant result, but if we just look at the data, we are seeing a better performance in the in-phase condition. And again, similar to the errors, we're looking at a lower distance or a shorter distance for the in-phase condition to consider this success, because we want this measure of entrainment to reflect the production of the speaker with aphasia and the audiovisual model to be as close together, as synchronized as possible. Therefore, the distance between their two productions, we hope to be as small as possible. And that we see here where the in-phase condition elicited arguably better entrainment. We note here that the anti-phase condition did allow for better entrainment than the sham condition, which is interesting and something I'll talk about more in the discussion. So going back to our original hypotheses, what we end up seeing is that in-phase tACS stimulation does tend to perform, even when not statistically significantly so, across linguistic and entrainment variables better than the sham and anti-phase conditions. And we do also see this pattern where the anti-phase tACS, although I had hypothesized that folks receiving this condition would do worse than their baseline, sometimes they are showing actually better performance with this anti-phase tACS as compared to their baseline. And I'll talk about this more in the discussion, but that may suggest that there's something to just receiving some type of this alternating current stimulation that's recruiting these residual networks and allowing for some enhancement of behavioral performance. All right. Closing out with results in the brain-based predictors here. Again, I had looked at the brain-based predictors with respect to these same linguistic variables, and I had considered them in the context of tACS success. So a higher number here would indicate a better performance, either in relation to the anti-phase condition or the sham condition. What I found was that preservation of the left post-central gyrus and the left external capsule contributed to better behavioral performance, specifically a greater number of tokens for the in-phase stimulation condition as compared to the sham. All right. And in terms of connectivity, there are a number of analyses that were run and a number of results here. I'm just going to filter out the most important here. But in one of the final connectivity analysis, I considered just these critical ROIs, right? So the ones that Lisa found in her publication really facilitated improved connectivity with speech entrainment, those same ROIs that were used as points of stimulation in the left hemisphere for the current study. And what I found is reduced synchrony between this left inferior frontal gyrus parsoprocularis and posterior middle temporal gyrus was associated with a greater tACS boost, so a better performance for the in-phase condition as compared to the sham for that linguistic variable of tokens. Okay, and that's what this looks like here. And this, of course, was contrary to my initial hypothesis. I thought folks who had more residual connectivity would benefit more from the stimulation, but it seems here to be just the opposite, that perhaps folks who have the least amount of coherence or have the greatest amount of damage to these anterior posterior resting state functional connectivity networks, particularly between IFG and MTG, really benefit most from this application of stimulation. Okay, so again, I think this is particularly relevant and a very exciting finding that might illustrate or give us some more information on not only the underlying neural mechanisms of speech entrainment, but specifically what's happening in the presence of stimulation. All right. So as I discussed at the beginning of this talk, it's understood that rhythmic brain activity interacts with rhythms both internally and through external environments through some mechanism referred to as neuronal entrainment. And we can think about this entrainment in a variety of different ways, especially when it comes to communication. We can think about conversational entrainment, this speech entrainment, so this one-on-one in practice with an audiovisual model, like I talked about here. But we also know that entrainment exists in other settings as well, such as this rhythmic movement in response to an external stimulus, as well as cortical entrainment and tracking, which is becoming more popular as we begin to think about brain interface systems and measures like ECOG. We also importantly know that speech processing and auditory processing relies on rhythmic activity, which, as we know, was a primary motivation for including speech entrainment in the current study. We also know from work in our lab and others that speech entrainment really does, purely as a behavioral model, promote successful entrainment for nonfluent aphasia. As I mentioned at the beginning, aphasia is thought of as a network disorder. We know that lesions do not necessarily occur in isolation. There are remote and even distal areas of the brain that are injured after a stroke, and some have even referred to aphasia as an oscillopathy, indicating that there's perhaps some pathology to the oscillations themselves following a stroke. This aberrant oscillatory pattern would therefore reduce in this poor synchrony that we see in language impairments that are hallmark in aphasia, particularly non-fluent aphasia, and we associate this with their ability to be successful in a treatment like speech entrainment. The idea here was that this slowed oscillatory activity as a result of a stroke may benefit from an external modulation where we could align the oscillations, reset them, and amplify them to a phase that's most beneficial for really enhancing processing, especially when this is done in phase and at a frequency that is inherent to those oscillations. And ultimately recreate or reestablish or create some proxy for this communication via coherence that we know is talked about in terms of neural rehabilitation and just neural networks in general. But thinking about this, of course, here in more of a rehabilitation approach. All right, so I've talked about a bit of this. We do see, again, both with significant or trending significant results, as well as results that aren't necessarily significant, but are showing similar patterns, that there's an improved behavioral performance for the in-phase TACS condition. And this suggests, again, given this proof of concept study with a small cohort of participants, that an exogenous boost of this in-phase theta stimulation may enhance connectivity and consequently this coupling between frontotemporal areas. As I mentioned, we found those with reduced functional connectivity in these frontotemporal areas did benefit most from TACS. And although I didn't use EEG or really any measure to determine what the underlying neural mechanisms here are, theoretically we could might suspect, that something like the afference copy, which has previously been proposed in the context of speech entrainment, might contribute to this non-fluent speech we see clinically, and that this damage to these anterior posterior connections would benefit from a presentation like speech entrainment of an audiovisual model, coupled with this external stimulation, kind of, in theory, doubly enhance this damaged efferents copy and refacilitate that ability for frontal and posterior regions in the left hemisphere to begin communicating again, or perhaps to a degree that they did pre-stroke. All right. So of course, I can't leave out clinical implications. I understand that non-invasive brain stimulation is used widely in research. We are seeing it in some clinical settings, but I do think it will be some time before it's readily implemented there. But I think it's important to think about how we can apply novel approaches in the field. This, for example, the study suggests that pairing this adjuvant of tACS may modulate neural oscillations to perhaps improve effectiveness and efficiency of rehab. We know from a recent publication by Dr. Susan Duncan, when queried, people with aphasia are receptive to receiving tDCS. This, of course, queried them on tDCS, not tACS, but it's a very similar non-invasive brain stimulation. And we know from one of my recent publications that clinicians on the other side are certainly receptive, but there are a number of barriers in place at this time on a variety of different levels. Okay, in terms of future directions, I look forward to expanding this work using a larger cohort of participants. This, as I mentioned at the beginning, is a presentation on my dissertation study. I recruited 18 individuals, 13 ended up being included in final analyses. We, of course, need increased power. Power analysis suggests a cohort of perhaps 30 to 35 individuals would really lend themselves to see effect sizes. Future directions would also include some measure of electrophysiological measure. As I said here, I used retrospective neuroimaging data to create the coordinates and to run neuroimaging analyses, but including MEG or EEG would be hugely informative. And as is the case with behavioral aphasia therapy in general, as well as stimulation, there's a lot to be learned in terms of dosage and duration, amplitude, where we're stimulating, who we're stimulating, for how long. And I certainly think it's worth investigating. We've seen success with tDCS. Dr. Friedrichsen's most recent trial with tDCS was with a much larger cohort, yielded very positive results. Does tACS allow us to gain more? Is there an edge that tACS might have on tDCS? And then, of course, as we continue thinking into the future, although not too far, I suspect, as groups such as Dr. Eddie Chang at UCSF have proposed, we may be really able to modulate these oscillatory patterns or these patterns of damage through measures like ECOG, neuroprostheses, brain-computer interfaces to really enhance recovery for these individuals. So as I wrap up here, I know I'm running short on time, but I am near the end. A limitation, as I mentioned, this is proof of concept. This was done in the context of a dissertation study. More people need to be recruited. Neural mechanisms need to be more carefully explored. I do recognize the controversy regarding the nature of entrainment, both internally and externally, and I think that's worth considering. And as mentioned with future directions, the limitation of the current study looked at 1 milliamp of amplitude of stimulation. It looked at 1 frequency, that was the theta band, and it looked at, although individualized coordinates, really 2 ROIs, anterior and posterior in the left hemisphere. All of these things can be modulated and individualized further and are certainly worth considering for future studies. But in closing, this proof of concept research was the first study to apply high definition tACS in a cohort of individuals with aphasia. And preliminary results do suggest a positive response to tACS. We see these patterns both in linguistic variables, entrainment variables, as well as brain-based predictors. And as I wrap up here, this research, as well as the research that is done in our lab, and for all of you who participate in aphasia research, would not be possible without the participation and willingness of our participants and families living with aphasia. I highlight a few important individuals here: my colleague, Dr. Lisa Johnson, my PhD mentor, Dr. Julius Friedrichsen, Abhi Datta from sotRx Medical, Dr. Roger Newman-Norlin, and Kyler Spell, both of the Aphasia Lab and ABC project at USC, who were hugely instrumental in getting this up and running, and a number of other individuals, both in the lab and otherwise, who I could not have done this without. So I will end there. I'm happy to take questions, and I want to thank you as the audience for listening. Again, it was a pleasure to present.
Thank you so much, Lynsey. That was a wonderful talk. Thank you. I'm going to open up the room here at C-Star for some questions first, and then I know that there are a couple of questions already in the chat box that I'll read to you afterwards. And a hand shot up for Roger Newman-Norlin, so I'll let him go first.
I just have a question with regards to speech entrainment. I think you were nice to give Julius credit for it, but wouldn't you say that speech entrainment is as old as language itself?
I mean, you can absolutely consider it in that respect. I was giving Julius credit for the speech entrainment paradigm specific to non-fluent aphasia, but we know that that paradigm was derived from older just models of language, as you're referring to, Roger, and human communication. But it's also important to mention, right, the work of Dr. Rosenbeck, who used this idea of entrainment with apraxia of speech, this idea of melodic intonation therapy that's been used in rehab for decades earlier than this particular paradigm was introduced. Yeah, so I do recognize that. Yes.
So my follow-up is, so you gave them speech entrainment, and this doesn't have to do with stimulation so much, but if you give someone speech entrainment that's never done it before, you're kind of teaching them a way to relearn how to speak a language. And could that become part of a virtuous cycle where you kind of kick them off with showing them this very constrained program, and then they could apply, you know, the points that they're paying attention to in the real world, and they could go back for more speech entrainment and then apply it again to, like, watching the Terminator, watching him say, "I'll be back," over and over again, right? Until they get it right. Like, why is a speech language pathologist even needed? I mean, you can just go on YouTube and watch the same video over and over again. So I wonder if this is, yeah, if you can just do this in real life. You can even buy brain stimulation stuff there.
Okay, so there's multiple levels to this question. First of all, I want to endorse the clinical credentials of a speech language pathologist, that they would be influential in the practice of speech entrainment. Absolutely, someone could do this on their own, but I would argue that they wouldn't get the same benefit as doing it in a rehabilitation setting with a clinician. I know just from anecdotal stories from Dr. Mary Aitchison, who's leading a speech entrainment study right now, there's something to be said to stopping individuals before or after a script set to, are they comprehending it? Are there certain metacognitive pieces of this that we can capitalize from a rehabilitation perspective? Are there words that are more challenging? They have a coexisting motor speech disorder. Can we work on that in tandem? There's pieces of the speech entrainment model that we can pull from. And I think getting the participant to outwardly reflect on what is their experience with speech entrainment. Is this easy? Is it hard? No, it's not necessarily naturalistic like you're saying, but I think, and I suppose I speak for at least some clinicians here, the goal is then, of course, they're not going to be practicing with speech entrainment and using that as their functional communication. Our goal is to, over time, reduce that scaffolding so that they have more functional communication and can use what they've learned from speech entrainment and from their SLP to carry out those functional and spontaneous language independently.
Question from Sarah.
So, Lynsey, this was such an ambitious project, and I love seeing the results all come together. I've been really interested in, like, confidence and sort of loss of inhibition in people's performance, and I was wondering what your thoughts are on like, do you think the participants knew which of the three conditions they were in, like if they were actually receiving sort of the treatment or not, essentially? And if you think that may just them knowing, or not knowing that they were having current on their, received, if that could change their performance on the task, that they might actually be trying harder or being willing to throw out more content if they thought that they were.
Yeah, that's a great question. So as I mentioned, participants, every day that they came in, at the end of their session, they were queried whether they thought that they received the sham condition or an active stimulation. And there was no significant difference there. Participants were not able to determine their condition. So that demonstrates that the study is double-blinded, but I will say anecdotally, once I was unblinded to the results, before I was unblinded, at the end of every session, I would make notes to myself. If the participant had commentary, if they reflected, it was easier today, or I felt better today. And once I was unblinded to the results, there is some alignment there with receiving stimulation and anecdotally reporting that, yeah, I felt better today, or that was easier, and it wasn't always on the third day, which I think is important, because as Roger said, right, this is a task that's practiced over time. If they come in and do this for the 45 minutes over 3 days, in theory, the third day, they're really getting the hang of speech entrainment. But their reports of feeling at ease, or perhaps with a greater confidence, really did align with their receiving the in-phase stimulation, which I think is interesting. And I will also say anecdotally, having worked in the aphasia recovery groups, folks who had come off of the speech entrainment treatment with Dr. Mary Aitchison, which of course is over a greater number of weeks, anecdotally, there was absolutely an increased confidence and just spirit about their language after that treatment. That is anecdotal, of course.
I'm going to ask a couple questions from the chat box. So Kirana Sapini asks, mentions, great talk, Lynsey. How are processing efficiency and better connectivity determined? She asks a series of questions, so I'll let you take one at a time. So how is processing efficiency and better connectivity determined? And are all of those outcomes based on trained scripts?
Okay. Yes. So Kieran, I was primarily looking at trained scripts. I was only taking outcomes after their 25 minutes of stimulation. So I didn't look for generalization effects. Those I did look at were not significant. The improved synchrony I use as a measure from the resting state functional connectivity. So I'm talking about synchrony as a proxy for resting state functional connectivity. And again, I derived that measure from retrospective imaging data. I did not perform new data for this study, but that is something that needs to be identified further and measured to a better degree using something like EEG. Processing, I had mentioned in some of my background slides, and that is used in more of a theoretical construct. I was really looking at processing here in terms of those linguistic variables, like the proportion of words produced from the script, or number of tokens produced, or number of errors, as well as that entrainment variable. That's how I kind of looked at their processing, which here I would specify to be production as opposed to really processing.
Kirana continues, was there any transfer to untrained scripts for tasks? And then her last question, were there individual differences in the patterns, especially for the number of tokens and entrainment?
Yeah, so lots of great questions. When I looked at the washout period, those were untrained scripts. There was no significant carryover. Again, though, this was only 25 minutes of stimulation, so I didn't really expect to see anything there, and didn't. I did not include any discourse samples before or after, which when I continue this work will absolutely be something I look at to see if this transfers to spontaneous speech after stimulation, as well as functional language measures I would love to include. And I love your question about differences in patient performance. And I want to quickly, are my slides still up?
Yep.
Okay. I want to quickly show this slide. I realize it's 1 o'clock. I'll make this really quick. Because there is considerable heterogeneity in patient responses. And I think that this is also worth considering. And it's important to consider, right? I included a cohort of folks with non-fluent aphasia. Not everybody with non-fluent aphasia presents the same. We've got those hallmark characteristics that I use to recruit, but some folks are, in general, everyone's doing better with the in-phase condition, but some folks, right, do far worse with this sham condition and do get some benefit from this anti-phase stimulation. So in terms of future directions and thinking about this, in addition to where we're stimulating and at what amplitude and frequency we're stimulating at, there's so much variability here, as we know exists in post-stroke aphasia, which makes this such a challenging area to study, that individualizing this is really going to be important, especially as we start to think about clinical translation.
Okay. Katerina Breitenstein asks, do effect sizes of TACS and tDCS differ in behavioral interventions in post-stroke aphasia? And do you have any data on long-term effect of TACS?
So I don't have information on the effect sizes in tDCS versus TACS for aphasia. And that is something I look forward to doing in the future, especially with comparable cohort sizes. In terms of long-term results for TACS, there's data out there to support improvements that sustain a few weeks out, but this work is really specific to either motor learning or memory, for example, has been a big target of TACS, but we don't have enough right now in the aphasia world to report on that. I do know, however, there are other groups who are working on applying TACS with aphasia, so hopefully in conjunction in the coming years, we'll know more.
And then two more last questions. One from Heather Dial. Hi, Lynsey. I really enjoyed your talk. I have a clarification question. Is in-phase versus anti-phase referring to whether the left IFG and PMTG were stimulated in-phase versus anti-phase?
Yes. Yes. So it's a reference to those stimulation points either being administered at 0 degrees phase difference between anterior and posterior, or anti-phase where it was 180 degrees difference. Good to see you, Heather, or hear you.
Roger shared a link for your pleasure later. Pansy Payne asks, I think the final question for the day. In the experimental process, the first part that subjects received TACS stimulation while they were practicing speech entrainment, is that correct? I'm not clear on that first question, but I'll continue with maybe you can shed some light on it. If so, then my question is that it would be confusing, or it would, excuse me. Then my question is, that would be a confounding variable that the TACS actually affects learning and practicing, not the production of speech. So I think you can speak a little bit to that, maybe practice effects, and how might practice effects influence these results on it being a TACS effect or a practice effect?
Yeah, thank you. Thank you for that question. So one way I eliminated the confounding factor of practice effects was using the randomization. So as I mentioned, the scripts were randomized, and then the participants also received different stimulation conditions in a randomized manner. So I would argue that learning effects are not of a concern here, because folks may have received in-phase on their first day, they may have received it on their last day, they may have received it on their second day, to which point I wouldn't be concerned about acquired learning effects.
Lots of compliments from Rebecca Hunting-Pompom, Emily Garnett, and Kirana Sapkini. Just to note, in case you missed this after this ends, Rebecca Hunting-Pompom wants to chat with you about some stuff that you mentioned about the variability that you showed.
Looking forward to it.
Thank you so much, Lynsey. This was fantastic. I'm sure if anybody has lingering questions, they can reach out to you via email.
Yes, please. Thank you all for your time. I really appreciate it.
Thanks, Lynsey.
Bye, everyone.